Cervical radiculopathy is an musculoskeletal disease, neurological condition. Look at this picture, shows that no compression due to herniated disc. Look at this. Spinal nose. Then X-ray C-spine findings, MRI, look at these findings, and CT scan, myelogram. If MRI is contraindicated, look at these findings, detail going on. Introduction. Cervical radiculopathy is a neurological condition characterized by pain, weakness, or numbness radiating from the neck into the shoulder, arm, or hands due to nerve root compression or irritation in the cervical spine. This condition commonly affects individuals in their 40s to 60s and can significantly impact quality of life if not properly managed. Definition. Cervical radiculopathy is defined as a dysfunction of a cervical spinal nerve root resulting from compression, inflammation, or injury causing motor, sensory, or reflex changes in the corresponding dermatome or myotome. Etymology. The term cervical radiculopathy is derived from Latin and Greek roots. Cervical refers to the neck from Latin cervix meaning neck, and radiculopathy comes from Latin radicula meaning little root, and Greek pathy meaning disease or suffering. Together it describes a condition involving disease or dysfunction of the nerve roots in the cervical region. Epidemiology. Cervical radiculopathy affects approximately 85 out of 100,000 people annually, with a higher prevalence in individuals aged 40 to 60 years. It is more common in men than women and is often associated with occupational or lifestyle factors involving repetitive neck movements or heavy lifting. Types: 1. Acute cervical radiculopathy. Sudden onset, often caused by trauma or herniated disc. 2. Chronic cervical radiculopathy. Gradual onset associated with degenerative spine conditions. 3. Unilateral radiculopathy affects one side of the body. 4. Bilateral radiculopathy affect both sides, less common and often more severe. 5. Recurrent radiculopathy. Symptoms resolve and return over time. Causes: 1. Herniated cervical disc. 2. Cervical spondylosis, degenerative disc disease. 3. Spinal stenosis. 4. Tumor or cyst. 5. Trauma. 6. Infections. Epidural abscess. Example. 7. Rheumatoid arthritis. Risk factors: 1. Age 40 to 60 years. 2. Repetitive neck motion or poor posture. 3. Smoking affects disc health. 4. Obesity. 5. Sedentary lifestyle. 6. Occupations involving heavy lifting or vibrating tools. 7. Genetic predisposition. Complications: 1. Permanent nerve damage. 2. Chronic pain and disability. 3. Loss of motor function. 4. Muscle atrophy. 5. Reduced quality of life. 6. Sleep disturbances. 7. Depression and anxiety. Pathophysiology: cervical radiculopathy occurs when mechanical compression or inflammation affects the cervical spinal nerve roots. This typically results from herniated disc or osteophytes, bone spurs that narrow the intravertebral foramina, causing pressure on the exciting nerve. Inflammatory mediators released in response to compression can exacerbate nerve root irritation, leading to the characteristic symptoms. Step-by-step pathophysiology of cervical radiculopathy. 1. Degenerative or traumatic changes in the cervical spine. Age-related disc degeneration, herniated disc, osteophyte formation, bone spurs, or trauma causes structural changes in the cervical spine. 2. narrowing of intervertebral foraminal stenosis. These changes reduce the space where spinal nerves excite the spinal canal, compressing the nerve root. 3. Mechanical compression of nerve root. The nerve root is pinched or compressed by herniated disc material, bone spurs, or thickening ligaments. 4. Inflammatory response. Compression leading to release of inflammatory mediators, example cytokines, prostaglandins that irritate the nerve root. 5. Ischemia and nerve root edema. Compression impairs blood flow to the nerve, causing localized ischemia and swelling, edema, worsening nerve dysfunction. 6. Demyelination and axonal injury. If prolonged, persistent pressure may damage the myelin sheath and axon of the nerve root, affecting nerve conduction. 7. Neurological symptoms appear. Resulting symptoms include pain, numbness, tingling, and weakness along the affected nerves, dermatome and myotome, sensory and motor disruption. 8. Central sensitization in chronic cases. Long-standing irritation may lead to heightened sensitivity and chronic pain due to changes in the central nervous system. Signs and symptoms. 1. Neck pain radiating to shoulder, arm or hand. 2. Numbness or tingling in the fingers. 3. Muscle weakness in upper extremities. 4. Decreased reflexes, example biceps, triceps. 5. Loss of coordination or dexterity. 6. Headache, occipital region. 7. Pain exacerbated by neck movements. Diagnosis. 1. History and physical exam, assessment of pain distribution, muscle strength, reflexes. 2. Sperling test, provocating maneuver to reproduce symptoms. 3. Imaging. A. X-ray for spondylosis. B. MRI preferred for soft tissue and nerve root evaluation. C. CT myelogram alternative if MRI is contradicted. 4. Diagnostic test. A. Electromyography EMG. B. Nerve conduction studies NCS. Nursing diagnosis. 1. Acute pain related to nerve root compression. 2. Impaired physical mobility related to pain and motor weakness. 3. Disturbed sleep pattern related to discomfort. 4. Risk for injury related to sensory or motor deficits. 5. Knowledge deficit regarding disease process and management. Medical management. A. Pharmacologic. 1. NSAIDs, example ibuprofen. 2. Muscle relaxants. 3. Oral corticosteroids. 4. Neuropathic pain agents, example gabapentin, pregabalin. 5. Epidural steroid injections. B. Surgical. 1. Anterior cervical discectomy and fusion ACDF. 2. Cervical disc replacement. 3. Foraminotomy. Nursing management. 1. Pain assessment and management. 2. Educating about proper posture and ergonomics. 3. Assisting with activities of daily living ADLS. 4. Monitoring neurological status. 5. Supporting with physical therapy recommendations. 6. Encouraging adherence to medication and follow-ups. Treatment options. 1. Conservative management. A. Physical therapy. B. Cervical traction. C. Lifestyle modifications. D. Use of cervical collars. For short term, two, pharmacologic therapy, pain control and inflammation reduction. 3. Minimally invasive procedures, steroid injections. 4. Surgical intervention for severe or refractory cases. 5. Alternative therapies, acupuncture, practice care with caution. Psychosocial medicine. 1. Cognitive behavioral therapy CBT for managing chronic pain and anxiety. 2. Support groups sharing experiences and coping strategies. 3. Stress reduction techniques, meditation, deep breathing and relaxation. 4. Patient education, understanding the condition to reduce fear and improve adherence. 5. Counseling services for patients experiencing depression or reduced quality of life. Prevention. 1. Maintain good posture. 2. Regular neck strengthening exercises. 3. Avoid repetitive neck strain or trauma. 4. Use ergonomic workstations. 5. Maintain a healthy weight. 6. Avoid smoking. 7. Regular physical activity. In conclusion, cervical radiculopathy is a prevalent and potentially disabling condition resulting from cervical nerve root compression. Early diagnosis, multidisciplinary management, and patient-centered care are crucial in improving outcomes. Both conservative and surgical treatments can be effective with a strong emphasis on prevention and psychosocial support to enhance recovery and quality of life. Thank you. Have a nice day.